So other adjuvant data that were of importance was the Adjuvant Denosumab data, long-awaited DCARE trial, and an update on ABCSG 18. So Komal, could you summarize those for us?
Yeah. I think we obviously know where denosumab is indicated and use that very comfortably, right? We know that we use that for patients with bone loss in the early stage setting. We know we use it for patients in the palliative setting for preventing skeletal morbidities. But I think the question is, can we use these agents to improve the outcomes in the early stage setting? And I think that was the question that was set out, at least as a secondary endpoint in the updated data from the ABCSG 18 trial and the primary endpoint of the DCARE trial that you just mentioned. Both showing conflicting results, actually. So not kind of quite answering this question very straightforward way for us. So the ABCSG 18 trial, we heard the primary results from Michael Gunnan last year. And that was that when you have a patient on adjuvant AI and you give them an adjuvant denosumab, you actually reduce the risk of clinical fractures, which was their primary endpoint, by 50%. So instead of 16%, it was 8% in that study. What they presented this year was the updated results for the secondary endpoint, which was disease-free survival benefit. And what they showed, both at 5 years and 8 years, that patients who got denosumab versus placebo, there was an 8% improvement in the disease-free survival. So 81 to 89% at the 5-year mark, same 8% differential at the 8-year mark. And kind of suggesting that, yes, when we give denosumab every 6 months for 5 years with an AI, there is a disease-free survival benefit. The DCARE study is different than the ABCSG 18 study in that those patients, majority had received an anthracycline and a taxane-based chemotherapy regimen. So over 95% had that chemotherapy regimen. This trial is large, it's 4,000 patients. And patients were getting this chemotherapy and then were either getting denosumab or placebo, but the scheduling is different than the ABCSG 18. Patients got denosumab here monthly for 6 doses, and then every 3 months for the remainder of the duration. And 20% were also HER2 positive. Majority were node positive, about 94% were node positive. And in this patients, the primary endpoint was set out to be bone metastases-free survival. And what they saw was that there was no difference between the denosumab and the placebo arm for the primary endpoint of bone metastases-free survival. So kind of negative. What was also seen was a 5% rate of osteonecrosis of the jaw. About 122 patients developed osteonecrosis of the jaw, which kind of probably goes with the scheduling. I think it was more intense scheduling compared to the ABCSG 18 trial. So yes, based on the DCARE, we don't know exactly how the adjuvant denosumab story plays out.
It kind of reminds me of the early data with zoledronic acid, right? We had the ABCSG study in the premenopausal women, that showed ABCSG 6, I think, that showed a real improvement in outcomes. And then the Azure study came out, and I was texting my NP, stop giving zoledronic acid to it. It took a meta-analysis to really tell us it's primarily the postmenopausal patients. And this study took young and older women, and it was just a big mishmash of everyone with breast cancer.
Well, it's interesting that the ABCSG trial is looking at these 2 bone remodeling agents, that where they showed a benefit was in patients receiving endocrine therapy and no chemo.
Right.
And I think that that's an important aspect of these trials, because it's possible that chemotherapy affects the ovarian function, and you've got the endocrine therapy part of it, and all sorts of different aspects. So maybe a higher risk population. Certainly in the DCARE trial that was the case. So we still end up with a lot of difficulty knowing exactly who benefits, even with zoledronic acid, with these bone active drugs, but clearly somebody does in terms of bone metastases.
And so for practice, denosumab is indicated for AI treated postmenopausal women who are osteopenic or osteoporotic. So we can reliably, go with that in our practice. Of course, we have zoledronic acid, of course, every 6 months as well on the NCCN guidelines for patients.
Although I have to say, denosumab is not approved in that setting.
Right.
It's certainly not in California, but
For osteopenic patients, yeah, because it's FDA approved. FDA approved.
it's
but
FDA approved,
right.
but it's more expensive. So most
Right.
insurers want you to give zoledronate, but we can be happy giving zoledronic acid in that setting. So
For our postmenopausal women, we should be using one of the bone agents in their care. But it is encouraging. That's probably the best hypothesis, that the patient populations were just so different in the two trials, and the ABCSG-AT was much more narrowly focused on the homogeneous population of postmenopausal endocrine therapy treated, AI treated patients, and looked quite good.
And I think there's intrinsic differences in these two cancer types, that were represented in this study. If you look at hormone receptor positive disease, CTCs is much more predictive of outcome. The bone seems to be an important microenvironmental factor and maybe even reservoir for micrometastases. So anyway, that's just a hypothesis. I think there's so many differences between the CARE-D and the ABCSG-18 trial that it's hard to sort that out.
Yeah.